Thank you for joining us, everyone, today. You've reached the Choosing Wisely Campaign's September Learning Network webinar. And as a notice, this meeting is being recorded. To remind you, during the webinar, if you could keep your phones and speakers muted or microphones muted throughout the presentation, and then open them up during chat. If you do have a question that you want to ask while the speakers are speaking, I invite you to use the chat box, which is in the lower right-hand corner. I'm going to turn the webinar over to my counterpart, Dr. Rothschild from Consumer Reports, and guru of all patient things. Becca.
Great. Thank you, Kelly. And hi, everybody. Thank you for joining us today. Today's webinar is called Engaging the Patient in Overuse at the Point of Care. And I'm super excited. We have two great presenters today, Dr. Moriates and Dr. Gupta, to share this information on this topic with us. So I am going to give a little background on each of them and then turn it over to the two of them for their presentation. They'll be co-presenting. And as Kelly said, feel free to put questions at any point into the chat box. And we will be sure to have time at the end of today's session for your questions and for answers. So a little background on both of them. Dr. Chris Moriates is the Assistant Dean for Healthcare Value and an Assistant Professor in the Department of Medicine at Dell Medical School at the University of Texas, Austin. He is responsible for creating an innovative curriculum for value-based healthcare for undergraduate, graduate, and continuing medical education, as well as building a robust value improvement program that engages healthcare providers across the healthcare community in Austin. Dr. Moriates co-authored the book, Understanding Value-Based Healthcare, which Dr. Atul Gawande called a masterful primer for all clinicians. He led the creation of the University of California at San Francisco Cost Awareness Curriculum for Internal Medicine residents, which was described in Jama Internal Medicine and featured in a perspective article in the New England Journal of Medicine. He is the founding editor for Teachable Moments series in Jama Internal Medicine. He is also the director of implementation initiatives at Cost of Care, a global nonprofit organization curating clinician insights that drive better care at lower cost. He previously worked with the American College of Physicians on their National High Value Care Curriculum, and he co-chairs the annual Cost of Care ABIM Foundation Teaching Value and Choosing Wisely competition. He speaks internationally on topics related to educating clinicians about healthcare value and how to implement high-value care programs. Prior to joining Dell Medical School, Dr. Moriates was an assistant professor in the Division of Hospital Medicine at UCSF, where he led the UCSF Center for Healthcare Values Caring Wisely program, the Division of Hospital Medicine High Value Care Committee, and the Internal Medicine Residency's Cost Awareness Curriculum. So as someone who lives locally in the Bay Area, we are sad to have lost Dr. Moriates at UCSF in the Bay Area, but UT Austin has definitely won by having him move there. I would also like to introduce Dr. Reshma Gupta to you. She is the Director of Outreach and Evaluation, as well as the Teaching Value and Healthcare Learning Network of Cost of Care Incorporated. She is a practicing internal medicine physician who trained for medical school at the University of California, San Francisco, did her residency and chief residency at the University of Washington, Seattle, and did a Robert Wood Johnson Clinical Scholars Fellowship with a Master's in Health Policy and Management at the University of California, Los Angeles. Dr. Gupta developed the Teaching Value and Healthcare Learning Network, a virtual community to advance and spread stewardship in medical training by showcasing promising value improvement strategies that can be used to disseminate best practices among trainees, educators, and health system leaders. Dr. Gupta works in health system innovation, policy, redesign, and education. She has focused her work to better define and improve the culture of value-based decision-making in care delivery, including the creation of the first high-value care culture survey. She has also led a multi-site study across California to understand drivers of value-based decision-making in academic medical centers in order to help develop future interventions promoting value. Dr. Gupta also works in consultation with the Innovation Center at the Center for Medicare and Medicaid Services Comprehensive Primary Care Program. In setting a national vision to train physicians in value-based care, Dr. Gupta has published numerous perspective pieces in JAMA, Academic Medicine, and the AMA Journals of Ethics, as well as holding numerous interviews with national radio outlets such as NPR. So with that, I will turn it over right now to Dr. Gupta and Dr. Moriates.
All right, thank you so much for the great introduction. We're happy to be here to talk about the topic for today, which is the effects of overuse and the culture of discussing overuse with your patients. Chris and I both left our Twitter handles here on the right side of the screen if you have any further comments or questions going forward out of this session as well to continue the discussion. So in this webinar, we hope to cover a few things. One, to better understand the desires of patients and the culture within our practices to discuss overuse with patients. The second, to choose your words wisely to avoid overuse. To describe 4 key steps to optimize having discussions with your patients to avoid overuse in their care. And to better understand how words can change the world. So in understanding the problem, overuse occurs when a drug or a treatment is given without medical justification. It includes treating people with antibiotics, with simple infections, or failing to follow effective options that cost less or cause fewer side effects. For example, antibiotics that are prescribed sometimes inappropriately for children's ear infections about 80% of the time, despite the findings that these infections can get better on their own, usually within 3 days without antibiotics. In healthcare, more is not always better. More spending or treatment does not translate into necessarily better outcomes in health. For example, inappropriately, an MRI or other imaging exams may or may not be valuable in a clinical scenario. MRIs often don't change the treatment prescribed for a patient's outcome, and the technology is an unnecessary cost, as well as incidental finding on an MRI can actually lead to other harms to patients, including further testing that can cause physical harm or complications, as well as emotional stress from that evaluation. However, we know that physicians can sometimes be resigned and feel that these adverse effects, if they're financial, physical, or emotional, are known and unavoidable harms of medical care. However, this argument has been made before in other examples, such as in central line infections, yet universal precautions have been implemented and have actually improved outcomes nationally. And we believe the same can be true for this movement with improving value and reducing overuse in discussions with patients. So one question that comes up, and often misconception, is that patients are not necessarily comfortable talking about overuse in discussions with their providers or costs. And what we know is that actually recent studies have shown that almost 2/3 of patients that were surveyed really want to talk about what is really needed in their care and have an open discussion with their providers. 2014, a New York Times study and by CBS actually found that 80% of Americans think that their doctor should discuss costs and overuse and recommendations in their medical treatment ahead of time. So discussing overuse and cost can be challenging. It's an issue of time, an issue of practice, knowledge, all products of having a high-value care culture within your practice. Organizational culture, somewhat like the water surrounding fish, is all around us, yet can be difficult to perceive from within. And culture, what we call as shared assumptions, values, and beliefs that exist in an environment, is a really powerful force that can shape practices of healthcare providers and contributes to overuse. We know that emergency physicians often are ordering unnecessary imaging tests that sometimes might actually be a response to a cultural response of uncertainty in making decision making. Similarly, there's a culture of overuse, which has been shown that medical trainees sometimes feel compelled to offer a choice of resuscitation to patients when it may not be clinically appropriate in their opinion. To create change in clinician behaviors, we will deliver the best care without overuse. The culture within microsystems in healthcare settings really needs to be addressed. And knowing that a decree from higher health system leaders above doesn't necessarily always translate to frontline providers and patients having these conversations and having these discussions openly. Taking culture change head on is really vital to sustaining improvement, reducing overuse, and will likely require a really step-by-step approach to iterative interventions and conversations that target gaps in culture of high-value care and in overuse. Chris and I actually recently developed a high-value care culture survey that was mentioned earlier. In a way, it's a way to help frontline providers and practices figure out where in their culture there are areas for improvement to improve culture of high-value care and reduce overuse. This tool should be coming out later this year. And Chris, I'll actually hand the section over to you next to talk a little bit about choosing your words wisely in conversations with patients.
Great, thank you. So I think Reshma very nicely set up the gap, the problem here. And the question, of course, is what do we do about it? And so we want to go through a couple things, both concrete things that we can do as individuals, as healthcare providers, or even as patients accessing care. And then Reshma will go through some other kind of systematic ways that we can deal with this. And then we'll close with really reflecting on the importance of the words we use. And so starting that discussion, there was an article published in JAMA Internal Medicine this past year by a trainee at UC San Francisco. And she called it Choosing Our Words Wisely. I think it's a great article that you should check out. And what she talks about is a case that she had where it was a young, healthy woman who came in. It was the first time she was meeting with Dr. Lowenstein, and she said, "But I want all the tests." And the doc said, "Wait, what do you mean? What do you mean you want all the tests?" And she says, "I want all the tests. I want to know that things are okay." And so the article really starts to reflect on what do we do when patients come in and they are requesting overuse or things that they don't actually need. This is a common struggle for many people and who see patients, and in fact is oftentimes blamed on the reason that we have so much overuse is, well, patients are asking for it. Maggie points out in the article, there's been relatively minimal emphasis in my training on translating the concept of value to patients, which of course I did the training on value at UCSF, so that was a little bit to my heart. But what she was talking about was, even though we're talking about value a lot, we're not really giving the words, the scripts to talk about this with our patients. And part of the struggle, she points out, comes from explaining complex concepts, such as the harms of overdiagnosis and overtreatment. And that the truly difficult task, I thought this was profound, is breaking the bad news that medicine is imperfect and we do not have the answers to every question. So what do we do? Well, she points out in this article, I think, something really smart, which was, there are a lot of parallels when you think about it between what we're trying to do with these discussions of overuse and bringing our patients along with that of our conversations about goals of care. They can be uncomfortable. There's some sort of gap between sometimes what our knowledge and the patient's knowledge and where they're coming from and what the goals are. And so she really draws on this to say we need to take lessons from how we have learned to have these goals of care discussions. And in some of the ways what we've done is experts in palliative care have developed straightforward language that we can use. And importantly, it relies on questions more than statements. So what this means is what you want to start, the first step, is to elicit a patient's understanding, expectations, and hope for their care. This is where, speaking for myself, I think we go wrong a lot of the time. We think that overuse means we have to explain away why that person doesn't need that MRI or that lab test or that antibiotic. And we start off and we want to talk and we start in our head thinking about concepts that are difficult, like pretest probability and epidemiology. And really what we should be doing is understanding what is it that they want. Why is this patient asking for all the tests? It turns out Maggie's patient, her dad had recently been diagnosed with metastatic cancer that was advanced and died quickly. Now, when you understand that, that's a completely different discussion than someone who comes in and you start trying to explain, well, we can't get all the tests. What do you mean all the tests? Well, there's this whole thing, choosing wisely and overuse and no. You understand, and now you can focus on her grief and her worries about her own vulnerability, rather than talking about pretest probability. I think once we start asking those questions, when we start understanding, the next step is to share knowledge, but once again, we can learn about making an alliance with patients, much like had been done with our goals of care discussions. So sharing knowledge to come to a decision together. Maggie writes things like, I wish there were a better test for this. Or, I worry about the unintended consequences. Or, I struggle with this uncertainty along with my patients. Think about how different that is than trying to convince somebody why they don't need something. Instead, it's about us together as a team. expressing the limitations, talking about our wishes together, but being clear that there's not much more that we can do that's going to solve this problem. So I want to pull in another study on this. So there was another study done actually by a group at Harvard, including one of our colleagues, Neil Shah, where they had given vignettes of 2 clinical cases, both to patients and physicians, looking at 2 of the Choosing Wisely criteria. So ones that we're all very familiar with, thinking about CT scans for headaches and thinking about antibiotics for respiratory infections. And a couple key takeaways from this. One is giant gap between patients and physicians when they read these vignettes about whether or not they thought the patient got excellent care. So that when the PCP did not recommend the CT for a headache, only about a third of patients rated that as excellent, whereas 81% of physicians thought so. But interestingly, when the PCP, when in the vignette, the PCP explains the potential harms of the CT radiation exposure, you see a big jump to 51%. Still not, what we'd all hope for, but a big moving people along to understand, who now more than half of those patients said, you know what, that was excellent care. The case was the same, the situation was the same, the outcome was the same. The only difference was taking the time to explain the harms of the CT scan. Similarly, in antibiotics, you see about 2/3 who thought the patient got good care by not getting antibiotics, probably because the message of antibiotic overuse has been getting out a little bit better, thanks to Consumer Reports and others that have been hitting that pavement for us all. But once again, when the PCP explains the American Academy of Family Physicians guidelines not recommending, you see a big increase again to 81%. The physicians already know the story, right? So they didn't really change when they read the vignette about the patient, about the explanation, which I also think is an important takeaway for us, because physicians sometimes take for granted what we know. And you think, well, of course the patient knows they don't need antibiotics for this. They still think that they're still asking for it. And so explaining sometimes to us doesn't actually come across as being helpful. And here you can see the big gap that indeed it is. And so the next key step is to clearly explain, but to do it in ways that, one, you're explaining the evidence and you're aligning yourself with the harms of this overuse, or you're aligning yourself, with the patient, and saying, we want to together avoid these harms. And so giving some clear-cut evidence about why you want to do that, and then talking about some of these aligning phrases. I wish there were a better test. I worry about the unintended consequences of this, the radiation that you would get from a CT scan. I struggle with the uncertainty along with my patients. We can never be 100% sure, but I am 99% sure in this case. And I think importantly, giving a clear follow-up plan, some contingency planning. And this might be a little more controversial. This isn't in Maggie's paper, but I've been thinking a lot about this as we've been wanting to talk about this. And one thing that I think is also important actually is allowing an out. So I think if we're going to be building trust, and part of this is about relationship between patients and physicians, there has to be some sort of give at some point. If you really want that CT scan, either we will come up with a plan to somehow provide that in some situations once you've had that shared decision making. Or perhaps say, you can go and get this care somewhere else. We don't want to make it too onerous, but I think when you make it seem like there is no out, like a patient is trapped and you're making the decision and you're not giving this thing, you're withholding it, that is an immediate way to lose trust with patients. So coming up with a way that you can ask questions, understand where they're coming from, explain, align your language with them, but then also give some sort of out, either contingency planning or for people who are really committed to getting this, they think it's the only way they're going to get good care, assuming it doesn't provide, you don't ever do something that is clearly harmful. So that, I think, are some of the key on-the-ground steps. I think Reshma is going to talk about some ways that we can optimize our conversations by transforming the culture, making it easier to do those things, and then we'll return to the importance of the language we use.
All right, thank you, Chris. So that was a great overview, kind of talking about, really thinking about what to do in these specific conversations with patients. And we both believe pretty strongly that culture change, when it comes to approaching reducing and avoiding overuse is a slow process that requires a number of interventions and also this very open communication. And we wanted to leave you with some really tangible steps of things that you can try, that you can use. And as Chris mentioned, words do matter, and we'll kind of go through some of these items here as well. So the 4 steps that we're going to kind of talk about is step 1, really asking patients about their concerns, which Chris had mentioned, and actually screening for some of these harms. The second is going to be understanding the value in recommendations. The third is actually working with patients and co-creating personalized care plans for them. And then the fourth is documenting, knowing that we work in a broad health system and need to coordinate care across multiple providers and locations. So taking the first one on is asking patients about their concerns and screening for harms. Chris shared some really great language of ways to choose your words. And I think when we're thinking about all of our patients within our practices, it's asking them very openly what their concerns are about doing tests or taking a treatment that might be recommended. And it'll open up a discussion about physical and emotional harms that might arise from some of the decisions that we make. I also wanted to share with you a really brief screening tool for financial harm, which is another type of harm that we sometimes will see, and asking how worried our patients are about their ability to pay for the medical care or having trouble paying for medications at home. And these are 2 things that can be done and used pretty quickly within a clinical setting to start discussing some of these things. So one question that might come up is, what specifically for financial harm, how does it matter to patients? And I really briefly wanted to just mention a study here that was actually done by the Kaiser Family Foundation that actually showed that more than 50% of patients actually report that they or another household family member did not do one of these following things in the last 12 months due to healthcare costs. That include skipping prescriptions, not filling them, missing appointments, things that all really do matter to both outcomes for their healthcare. So definitely important for patients wanting to talk about this. And we suggest using a universal precaution approach, almost universal screening, to think about all of our patients and how all of these decisions can affect them, both financially as well as those physical and emotional harms that we talked about. So one thing that often comes from that is ways of understanding what is the most meaningful to patients in managing their health and their finances. And I think a few important things are important to consider. When you're having these discussions, where are you? Where are they happening? Are they on the phone or in the clinic? And who's being involved? Is it just the patient and the provider? Is there a social worker that might need to be present and a family member? And just kind of thinking about the setting that we're having these conversations in. Another thing is really asking about what the burden is for the patient. What is their current concerns about their situation, the emotions that they might have regarding a decision to do a procedure or a test or take a certain treatment? And from the financial perspective, in the past, have they had financial stress before, or are they currently having a concern about making these payments? And that will open up discussion moving forward with them. One issue that often comes up, I think, in having these conversations is that, there's concerns from providers that they're going to lose time in patient encounters to do some of this screening. And, in the new era of the Affordable Care Act and working in team-based care, a lot of the screening can actually be done pretty routinely using your healthcare team, both for screening as well as to initiate some of these discussions. The second is integrating really seamless ways to capture screening in the health record, such as through an electronic medical record or using dot phrases, huddling with staff or medical assistants in the outpatient setting or other support staff and nursing in the inpatient setting. Third is patients who screen positive for having higher risk of some of these harms of actually getting flagged to have that deeper discussion face-to-face with providers. The second step we talked about is really understanding the value of recommendations. And there's really a couple components to that. It's both understanding what are the guidelines to make the medical decision that's going to provide high quality care. And the second is the financial ramifications of this as well for the patient. And the major component of this, I think, is really understanding where to go for these resources. So society-based guidelines, choosing wisely, some of these guidelines can help in terms of the medical components of it. And I think as time has passed, and as this New York Times article came out few years ago now, really drawing attention to price transparency, and knowing that there are a number of resources now that can provide relative costs, even if your local institutions don't have exact costs for things, there's relative costs that are often based off of reimbursement pricing. Having these conversations about overuse, as Chris had mentioned, can be challenging. And Chris and I both, working clinically, have a deep understanding of some of these challenges in these one-on-one conversations. And, question arises, could this open Pandora's box, especially in a short visit? But, I think the more that we do this work, addressing what's most meaningful to patients can help target feasible care plans, which in the end will have a number of benefits over the long term with patients. I actually have worked in a safety net medical centers, and often face patients who have issues ultimately trusting within the health system, which is something, Chris had just mentioned as well. And really having a co-creating partnership is the best way to move forward. I think a lot of folks will think that it's contrary to the initial thought that a hard discussion is going to lead to a long conversation actually be harder for everybody. And it's actually not true. The truth is that patients are really smart. They pick up on honesty. They pick up on providers that are really trying to advocate them. And when there is issues of trust that come up with the health system and, potentially not getting that CT scan or some other, diagnostic testing, as Chris had mentioned, brings up issues. And I think knowing that there's that partnership there and really understanding what the underlying concerns are with those patients can take a conversation far. Theoretically, it can actually save time for patients over time, getting a good plan that's feasible for them right up at the beginning. Patient satisfaction as their wishes are actually being addressed. Patient adherence, as well as provider satisfaction, that they actually feel that in a visit they got to the core of what a patient wants to do and probably will be able to do with their care, as well as cost saving for the patient as well as the health system. So the third step I wanted to share is how you actually co-create these personalized care plans with patients about how to avoid overuse, and once you understand where their wishes are coming from. And there's a number of outline kind of strategies that I think can be useful here. The first is really creating a real list of what the available options are. So in addition to that CT scan that we had mentioned earlier, there might be other things on the plate that could help us to diagnose whatever the issue is with the patient. If it's lower back pain, seeing physical therapy, and creating this list of both other options as well as potential harms of those options, and potentially even estimate costs to share with patients. Co-creating then with them a specific plan, being able to write it down and adjust it over many visits, knowing that patients' wishes can change over time. And then, taking these practical options and choosing the ones where we can see that harms weigh against the benefits, coming up with that joint plan, and then leveraging community resources, interdisciplinary team to actually make things happen on the ground. The fourth step we wanted to discuss is documentation, something we often forget about, but I think is actually extremely important. We often will have these conversations with patients, spending time going into depth, and if you look in the chart, one line will be entered in, had a conversation with patients about choosing something alternative to that CT scan. But as patients go between specialists, different hospital systems, the emergency rooms and clinics, and in the inpatient setting, documenting what these conversations are can be extremely helpful. And I think, especially when some of their wishes can change over time, things to think about to include are, what's most meaningful to the patient, as we've discussed. What are those risks of harms? Past history of how harms have affected patients, especially some of the financial harms that they, or barriers that they might be facing, and what the various management options were that you discussed and maybe chose against, because they can be revisited later. So I'll pass it back to Chris to kind of talk a little bit more about how words can affect the world.
Yeah. Thank you. I see a question here about thinking about how we can assist in this culture change in the community before patients are in the clinical visit. I think we should talk about that a little more as we go through. I mean, a lot of it is getting this message out, and in a lot of ways, our partners, both in journalistic realms, New York Times is focusing on this all the time now, frequently, and Consumer Reports is putting a lot out there. Campaigns that are doing that and starting to get it out. And this plays into what I wanted to talk about, which was that what we are talking about here is challenging. It is a culture change that requires all of us. It's not simply do less of something, or it's not as simple as a couple phrases that we can share, although that's the way you start to move this. And so what I want to make clear, there are a couple examples that we oftentimes draw on from cost of care. One is thinking about the green revolution, the environmentalism movement. That similarly is a movement that happened in our culture, in our communities over the past few decades. And yes, what really matters here is big policy change. And what matters is, how Apple is doing things in China, right? But that doesn't mean that we just sat around and waited for those things to happen. We took personal responsibility, and in the way we changed our entire world. So now there's, an expectation, a cultural norm. If you were to litter on the street, you'd be more than a little embarrassed, right? Especially here, in Austin or in San Francisco or in LA. And so are we embarrassed if we order an MRI that's wasteful, that's unnecessary? Are we embarrassed when we waste in healthcare, even though that waste is not even just going in a trash basket, but literally most of the time into patients' bodies and causing harm? And so we need to start to create that culture, and we do it one at a time, and we do it by leading from where we stand. I think it's helpful for us to reflect on another example in healthcare happening right now that is really looking at cultural change, and is surrounded in a lot of ways by the way we speak. So a few years ago, I was on rounds, and I stood at the foot of the bed, and I said, "Do you have any questions?" And I could feel the med students in the room start to slump their shoulders, because we still had 10 patients to see that morning and we were running behind. And I said, "Do you have any questions?" And immediately my brain began to chant, "Please don't, please don't, please don't." And my patient was an elderly woman admitted with cancer and shortness of breath. The fluid had built up around her lungs, was drowning her from the inside, something she didn't even know was possible until now. And I could see the uncertainty in her eyes, the fear. And she turned and looked at her daughter next to her, and she locked her eyes on mine. And it turns out she could read my brain. So she said, no, doctor, no questions." And with that, we all turned and we were gone. Just gone, like a Broadway scene change. And the thing was, I felt that my own satisfaction with my job was starting to slump. It didn't feel good to be doing this. And we started to focus on how we could improve quote unquote patient satisfaction at UCSF. And so as we did that, of course, there were campaigns and there were slogans and there were acronyms and there were online mandatory modules, right? But I don't think that really changed culture. That was important to set the standard. It was important for us to say as an organization, this is what we're doing and here's the new way of doing it. But what really changed was the way that we spoke. And there was a colleague of mine who decided to take it upon herself to lead this. She didn't have a title to do so, but she started teaching each of us these little, what felt like magic tricks. And then change was so small. So written out, it looks like there's barely any difference. But we started learning to ask things like, "What questions do you have for me?" instead of, "Do you have any questions?" And just that shift, the "what questions do you have for me?" made all the difference in how I ended my visits with my patients. Because now, "please don't" chants no longer applied. And everybody seemed to notice. And the amazing thing is that as we started to do that, it actually became institutionalized. People began teaching this way of interacting with our patients. It was simple. And sometimes I would go on rounds with a resident I'd never worked with before. And on that first day, we'd go in and see that first patient, and I'd hear her say, "What questions do you have for us?" And I knew that we were on the same team. We were part of the same culture, and we were trying to do the same thing. think about how that applies to our goal of overuse. How the words we use amongst each other, how the words we use in morning report, how the words we use when we train medical students and residents, and how we talk to our patients sets that tone and sets that culture. And how simple changes, asking about, admitting, I wish there were a better test. I worry about the unintended consequences. Let me tell you why the guidelines tell us that we shouldn't get antibiotics, or we shouldn't prescribe antibiotics in this situation. How that then spreads, becomes institutionalized, is I think really important. And so things like, and I know this is a flat out plug, but the Consumer Reports, 5 questions to ask your doctor, really important. That's the type of stuff. That's how we assist in this culture change. We get it out there, and then we help coach our own patients through those questions. Maybe hand it out in your own waiting room, right? This is what we want to talk about when we talk about testing. And so I think that's what we need to do, because it is those small acts that help transform the world while we're working on all the bigger machinations that have to happen behind the scenes to make that possible. So with that, I think we can turn over if you have any questions. What questions do you have for us? And I think hopefully we'll have a good discussion. I see a bunch of names that I recognize here on the phone, so I hope to hear from you.
Great. Thank you so much, Reshma and Chris. That was a great presentation, and great to hear all of that. And a lot of what you said brought me back to my days when I used to teach in an adult literacy program, when so many people came in with poor literacy skills, wanting to know how to manage their health care, and having just basic health questions and not understanding what their doctors had told them, and wanting to understand and wanting to do the right thing, and just not really knowing what questions to ask or what to do. So I don't know if we want to circle back to the question we have in the chat room right now from Kelly Slate-McTavish. What are your thoughts, Chris and Reshma, on how to assist in this culture change in the community before patients are in the clinical visit? So I know you mentioned, Chris, the New York Times, Consumer Reports, et cetera. I didn't know if either of you wanted to add to that at all.
Yeah, I can add to that. I think there is some movement out there right now of trying to get communities to really engage in having these conversations. So the questions, like Consumer Report questions that Chris had mentioned, but there's more media outlets as well that are trying to get it out on the radio, and to have patients feel more empowered that they can ask these questions and have them in the community. I think what's really interesting, and this goes off of what you had just mentioned, is that when you think about communities that are potentially under-resourced, language barriers, that are kind of not necessarily as empowered or know what to ask, how to engage them. And I think that's something that's probably a bigger question that hasn't been totally tackled, but I do think that there needs to be more work in kind of reaching out to them about beyond just a normal media outlet, about what medicine is, what these conversations are. Something that Chris mentioned really early on was that physicians, we often take for granted that using an antibiotic in a certain situation or not is the right thing to do or not, and we assume that our patients know that. And I think creating that gap and having that explanation is really, really important, especially with those communities.
Yeah, that's perfect. And I would just add to it, I mean, it's something that we've been thinking about here. So as I think was mentioned, I recently moved to Austin, Texas, and we're here at Dell Medical School, and thinking about who is that community. So when you say change out in the community, really defining that group that you feel you are most, I guess, responsible for or part of, and thinking about creative ways to get that out. And so we've been doing that on a local scale, thinking about, how do we get the message out to the surrounding Travis County here, and like Reshma said, to those folks who are not always privy to this message. And I think that is our role. So to be clear, no matter where you are in this healthcare environment, ecosystem is the word we like to use around here. We have a role in teaching and getting out there and coming up with some creative ways to do that. So podcasts out to the communities, creating some sort of handouts or different things that we can do. We're thinking about being able to go to schools and help engage schools, maybe not so much in overuse as healthy behaviors, but you see how this all overlaps. So I think that we do have a responsibility to our local communities to taking upon ourselves to think about how we can be creative to get the message out that what we really want is to promote health. And we really want to promote health, and there are ways to do that, and providing high value care and getting rid of over testing in medical care is one way to do that.
Great, thank you. I see another question has come in. In creating a Choosing Wisely campaign in my community hospital in Connecticut, it was often difficult engaging specialists to play nice in the sandbox. Any recommendations to get other doctors on board and to change their culture?
Yeah, absolutely. That's a common issue, and I've come across that frequently. I think there are a couple things here. One is I think we can only go so far. I believe one of the key components of Choosing Wisely was that it really activated and empowered and said, look, we're not going to tell you what to do. You come up with top 5 lists in your own specialty. And the thing is, as we know, when you do that, there's some times where the lists come out and you're like, really? That's what you're going to put? That's not what I would have picked for you. But the thing is, that is the progression that we have to take, I think, sometimes. So for me, it's been learning when and how to push. I'm not trying to say we just let this be, but sometimes the timing is not right. So when we went to introduce a telemetry project, the message at first was a hospitalist went into a group of cardiologists and told them essentially that they were overusing telemetry and that we had to cut back on telemetry, and he got eaten alive. It was terrible. And so a much better message is to try to go in and try to understand, where do you see the gaps in care? We think that there may be an opportunity in telemetry. Tell us about it. And really, just like we talked about, starting with questions, engaging them in those discussions, and trying to get them to move along, and understanding that it's not going to all happen at once. One more quick example before I move on, and so that I'm not totally trashing on specialists. In our own hospitalist group, I graduated residency. I joined the hospitalist group. We were going to tackle high value care stuff. I had Bob Wachter, my boss, who invented the word hospitalist, on board. He was, he's the one who wanted me to do this. And yet, when we said, we're going to look at daily labs and try to decrease daily CBCs, all of a sudden the war stories came out. All the attendings looked at me like, who are you? What do you think you're going to do? And they were very uncomfortable with it. And so instead of forcing that issue, we actually backed up and said, okay, let's look. Ionized calcium. Anybody have war stories about ionized calcium? And they didn't, but it was an outlier. We ordered a ton of it at UCSF, none of it at San Francisco General. And so we started a campaign, I Reduce iCal. And I believe that it was that toe in the door, because within 2 years, the residents came to us and said, we want to decrease lab testing. And then all of a sudden the war stories were gone. Now the whole world had changed in those 2 years with Choosing Wisely and all that. But I think we helped sort of move that along, and we figured out when the timing was right to really push. So I would just, the message there is try to figure out when you push, when you don't, engage them, ask them questions, and use their expertise rather than trying to tell them what you're going to do.
And I'll add to that a little bit as well. I think, as Chris said, getting that toe in the door, the early win is so important, especially when you're working with folks that haven't flipped the culture as much in certain, smaller groups within the medical centers in certain departments. And I think the other thing, one example I can share here is actually at UCLA. So what we've been trying to do is actually through the faculty practice group, so with the providers and with the specialists, is identifying a key champion to help improve value and reduce overuse in every department. And so it's someone who has buy-in that's internal within the department, that's starting that discussion within their own department to, in addition to the Choosing Wisely campaign, identify what those things are that are truly potentially harmful for patients, potentially overused, potentially costly, that are meaningful to both their patients, who they know deeply, as well as the health system. And identify each year a few of those to tackle. And having that champion from the inside, I think, is enormous because they can identify something that's an easy win that someone from a different specialty or generalist may not even know about. And they can also work with some of the folks that have been working for a long time and maybe questioning the purpose of doing it in the first place. And I think it's created a lot of change. And I also think if you're at an institution or in your practice and you actually have access to data where you can actually see where there's variation, and you can actually see what actually are you doing that is costly, and work with the specialist to create protocols of, where in these workups can we do some of this by generalists and in the outpatient setting, and what part of this protocol could we do when they hit the specialty visit, can actually streamline things so we're not double ordering and double working up things that often happens.
Thanks, Reshma and Chris. And that we hear that so often, I think, with a lot of the partners we work with and the grantees about the importance of champions, and really kind of building momentum from that perspective. Everyone, I want to remind you that the phone lines are open, so if you have questions, you can ask them out loud. You just need to unmute your own phone. And you can also, of course, add them to the chat room. As we're waiting for other questions to come in, I have another question that I've myself and that I've heard others who we work with frequently ask about. And that is, how do you change this conversation, or how do you have this conversation or choose the right words when you have a patient population that varies throughout your day, some with a very high educational level and some with a much lower educational level, and will come in with a lot of different background information and will understand things in a different way. How do you handle those conversations?
So I can,
Yeah.
we were both excited about this question. I can speak to that as well. So I definitely work both in a couple hospital settings where I'm working, like I said, with kind of lower income, non-English speaking patients, migrant farm worker type folks, and then later that week we'll be seeing someone who's an executive in a company as my patient. And so I think the questions that we get about, do I need this test? Should I be getting this additional thing? Are consistent. We see that on both sides. But I ultimately go back to the points that we made during the presentation, which is whenever someone's asking for something like that test, really understanding what their underlying concerns are about why they want it. Is it a family experience where someone's passed away from cancer, like a story like Chris had shared, where they're afraid that they have something, and then you can reassure them about the fact that they're not really actually at high risk for that? Or is it something that it has to do with their insurance plan and what the benefits are at the time for that year? And I think the discussion goes in two very different ways. But if you ask those questions, and I really feel this, they feel like you're partnering with them to understand what their real needs are. More often than not, I would say more than 90% of the time, we get back to a plan that is both what's medically appropriate and what meets their needs. Just spending a few minutes talking about it.
Yeah, I think Reshma answered that better than I would. I think I'll just add that, this is a challenge that we come across as healthcare providers on all topics. I mean, and it just underlines the importance of starting with questions, understanding where people are coming from so that you can diagnose, if you will, that gap. And so you know how to kind of frame your response. We really run in trouble when we make assumptions on both sides of the spectrum about what people understand and why they're, asking for what they're asking for or saying what they're saying.
I'll add one more thing too, is I think it's okay to make mistakes as providers. It's okay to have a conversation not go quite the way that you want it to, and to come back to it later and readdress it. And I think sometimes we don't give ourselves that flexibility, but it's a really diverse patient population that's out there, and sometimes we do approach it not quite perfectly the first time, and that's okay. And I think as providers, we've dealt with that in other situations, end-of-life care discussions, challenging conversations in other settings. And, I put some of these in that same category, and give yourself that flexibility to say, I'll learn from a bad conversation this time.
Great. I think what you said is so important. I had a provider myself who we were having a conversation of, and as the conversation went on and the appointment was ending, she came back and said, I don't know that I said that I really answered your question or addressed your needs, and let's rethink this and re-talk about it. And I admired so much that she was able to do that and willing to say that she had not done it in perhaps the best way or the most understandable way, and that made our relationship grow and made me trust her so much more as a provider. So are there other questions? The phone lines are open, as I said, so feel free to unmute yourself if you have questions.
Hi, my name is Eric Barbineau. I'm I'm an internist in the New York area, and I just wanted to, one thing that we've done, or I've done rather, is in addition to all the things that you mentioned, which were great, is when I am trying to talk a patient out of an unnecessary test, I give them my rationale for when I would order that test or when it would be a good idea to do, so that way I'm offline.
I'll kind of respond to that. I really appreciate that question, and I actually do the same thing myself, where when I'm talking to the patient about it's kind of that out that Chris had mentioned, and giving yourself that out is, here's my algorithm of how I think when it's appropriate to use a certain scan, and these are the conditions in which they're probably appropriate to use it for. And if we, come down that route, we're in that situation, then that's the appropriate time to order it. So they don't necessarily feel like you're completely withdrawing it, or there's a trust issue in who they are and what you're offering to them, but that there's a real medical rationale for it. And I think that's extremely helpful and actually educates.
Great, thanks, Eric. Are there other questions or comments that people would like to share? Again, you can just unmute your phone lines.
Hi, this is Eric Barbanel. Hi, I'm an internist in the New York area, and one of the things that I've done in my practice when seeing patients and trying to talk a patient out of getting a certain test is I'll give them my rationale for when I would order it, so that way they would know what to look for and why I think that not doing the test is the appropriate intervention. And that's worked very well for a lot of things, even when I'm seeing patients that I've never met when they're coming from urgent care or something on a first visit.
Yeah, thank you, Dr. Barbanel. I think that's a great insight. I think we lost you, and we heard you the first time.
Oh, so I'm sorry. My phone
just
fell on the
discussed that,
floor,
but I think that's a really
see that it was gone,
great tip.
Never mind.
That's okay. No, it's a great tip. We appreciate it. Thank you. Insight.
Great, thanks. We have just a few minutes left, so I just wanted to see if there's any further questions before I turn it back to Kelly to close us out.
If there's not, Becca, maybe 1 second, if I could, going back on kind of the question that Mark Safalo, I assume Dr. Safalo had brought up about engaging specialists. And I think we said this, but I just want to make explicit that one of the tools that we found, Reshma brought up data, and was really important, was giving people data and then letting them have the conversations about that. So the example is transfusions. We saw a big variation between different between different physicians on transfusions in UCSF. And one of the biggest discrepancies was between a neurosurgeon and an orthopedic surgeon who both did spine surgery. And they actually covered for each other's patients, and one was transfusing much more than the other. And I'm not dumb enough to go to the orthopedic surgeon and tell him he's transfusing too much, right? But what we did was we gave that data. We had the right spokesperson, which happened to be, in this case, the nurse manager on that spine floor, who had a great relationship with both of them, who just sat down and showed them and just said, look, there's, you guys are both practicing very differently. Why don't you talk to each other and try to figure out, because it's confusing everybody here when we have to do things differently. And that has been effective. I know I see there's some folks here from group health, I think, and I believe that conversations I've had with them, they've come up with some similar takeaways, which is, it's not that I've seen this tweeted out by their group. It's not the data, it's the conversations about the data. And I think that is
Great, thanks. And I do think also, with my background in health literacy and numeracy, it is the conversation. It's not just so much the data and showing it, but really talking it through and talking it through from in a different perspective with all patients. So thank you both so much, Chris and Reshma, for sharing today and for providing all this information. It's been great to hear your perspective. And I will turn it back to Kelly at the ABIM Foundation if she has any closing comments or any final announcements for the group.
Thank you, Becca, and thank you, Reshma and Chris. It was a really terrific presentation, and thank you for all the participants who came out, had great questions, and I don't have any further insights or announcements, so thank you for the day, and enjoy the rest of your day.
Great. Thank you again, Reshma and Chris. That was terrific.